All right, thank you all for coming and those great introductions, and welcome to everyone online attending the webinar. So excited to introduce our speaker for tonight, but before I get started, I wanted to just say a few thank yous, as we normally do, to ASM for hosting us and being such a gracious host and always having us here in such a great location. So thank you, Mark, and thank you, ASM, as well as for a thank you to the One Health Commission for hosting our webinar platform. So we are able to access everyone on their couches at home, getting comfy, maybe eating, we encourage you to support both of these groups, however you're able to, because they make this night possible. So thank you very much. All right, and without further ado, Dr. Mary Lancaster manages the Strategic Engagements and Emerging Threats portfolio for the Biological Threat Reduction Program at the Defense Threat Reduction Agency, DTRA. Dr. Lancaster leverages strategic interagency, international, and non-governmental organization relationships to establish and manage a portfolio of scientific and technical engagements that will enable BTRP to improve the breadth and quality of communication, coordination, and collaboration with external stakeholders and maximize BTRP's impact globally. She also develops the strategy and approach for BTRP to address emerging threats and opportunities, including synthetic biology, cyber biosecurity, microbial forensics, and countering biothreat networks. Previously, Dr. Lancaster served as the AFRICOM Science Manager for BTRP, managing BTRP's cooperative biological research portfolio in Africa and working with collaborators in 10 countries to strengthen biosurveillance capabilities and reduce the threat of pathogens of security concern. She also led the development of the 3rd Africa One Health Congress held in Johannesburg in February 2019. From 2010 to 2015, Dr. Lancaster was a research scientist at Pacific Northwest National Laboratory, where she applied her expertise in epidemiology and data analysis to a broad range of projects, including vector surveillance in the Republic of Georgia, blended cyber physical risk and vulnerability assessments, development of cybersecurity resilience metrics, and development of a proof of concept decision support tool for the biological event response that integrated epidemiologic modeling with decision theory to guide decision making under uncertainty. Prior to joining PNNL, Dr. Lancaster was the regional epidemiologist in the West Tennessee region of the Tennessee Department of Health from 2006 to 2010. Please join me tonight in welcoming Dr. Mary Lancaster.
Okay. Well, thank you for having me here. I appreciate the invitation to speak. Sarah, who actually nominated me for this or talked me into it, can't be here tonight, but I appreciate the opportunity. And thank you all for coming out. So I wanted to start with a bit of background about our program. Most folks have heard of DTRA. Fewer folks have heard about the Biological Threat Reduction Program, even though we've been around for 20 some odd years now. So we'll start there and then branch off into some specific examples of the One Health work that we've been doing around the world. So back to the acronym speak, we're with DoD. We're at DTRA. We're with CTR. We're part of the Nunn-Lugar Cooperative Threat Reduction Program. Having recently lost Senator Lugar, but we're the bio piece of that within DoD. That makes us the largest biological non-proliferation program in the world, and our mission, formal mission, is spelled out here. We focus our efforts entirely outside the U.S. So none of this is non-pro or counter-proliferation on the homeland. And our efforts largely are aimed under the pillars of biosafety and biosecurity and biosurveillance, as well as the research component. Sorry, notes are all out of order now. So these are our 3 main focus areas. We are primarily interested in building capability in our partner countries to enable those countries to detect, diagnose, and report disease events involving pathogens of security concern. Our activities run the gamut from infrastructure development and laboratory renovations, the development of SOPs, procuring equipment, providing pathogen collection databases. We have software that we are able to share with our partners freely to do pathogen asset control. Essentially, how do you inventory all of those lovely little vials that have been stashed at the back of the freezer since we don't know how long ago? And for those of us who are scientists in the room, you've contributed to that. Yeah. We also have are able to provide some electronic infectious disease surveillance software as well that can be tailored to individual countries. It is able to readily accept human health surveillance data as well as the animal health side. And in the Republic of Georgia, both the human and animal sides of the reporting system actually utilize it, and they're able to share information back and forth, which we thought was a significant win. We also provide a bucket load of training. It's great to do laboratory renovations and equipping. If you don't teach the people how to use the stuff that you've given them, it doesn't really do a whole lot of good. And so the training that we provide, I'll talk a little bit more about later, but it's operating in the lab. It also includes field work and exercises as well. We also work with and coordinate with international organizations, with WHO, OIE, and FAO. We've had that portfolio in place for about 5 years. And so some examples of the work that we have done with those organizations include OIE and WHO national bridging workshops, helping bring together joint MOH, Ministry of Ag, oftentimes bringing in the wildlife authorities to create roadmaps for activities to address their mutual gaps, and then prioritize those. This is part of the JEE and the PBS evaluations that are ongoing. We've implemented that in 10 countries. Now we have done tripartite development of One Health guidelines and operational tools. This is done in support with CDC and USAID. So creating a tripartite zoonosis guide made available to the member states. The final version is now available through their websites, so freely available. They have operational tools that are in development in 7 subject areas as well. So again, trying to build up that capability and spread the knowledge. And then we've helped fund CDC One Health expertise to FAO and OIE to put staff members in place to serve as public health experts and liaisons in those offices. This is another visualization of where we work, showing the biosafety and biosecurity pieces, as well as biosurveillance. We focus on select agents. Typically, the easy answer is the BSAT list for Health and Human Services and USDA, plus the pathogens that would be in a differential diagnosis with any of those agents, and they're near neighbors, and then also pathogens of pandemic potential. So things like MERS that would be on that list if we could modify it faster. So these tend to be the high consequence, low prevalence pathogens, not the rabies, the foodborne diseases, the stuff that the public health folks often are dealing with. These are often so we sometimes struggle in working with our partner countries. Rabies is their highest zoonotic disease priority. It's not something that we can work with. And so oftentimes we're having to shuffle and either alter a project that helps address their highest priorities within our mission space, or making the connections to other partners that can help address those issues. We also don't do response. Again, we focus on that detect, diagnose, report in accordance with international standards. We got pressed into the response corner during the West Africa Ebola outbreak, and that has been sort of the limits to our responsibility. There are other organizations that address that more completely. So you can sort of see that BTRP is not all things to everybody. We do have some limits to what we do and where we're able to operate. So one of the places where we have had significant impact is infrastructure updates. The picture on the top right is supposed to be a pathology laboratory. It's a bit problematic when the windows don't necessarily keep the wildlife out of the lab. The air conditioning is good because it means you can keep the windows closed, except perhaps you're keeping some of the critters inside too. So these are some of the low resource environments, the updates that need to be had. We're not going into all of our partner countries and putting in shiny big BSL-3 laboratories. They're not sustainable and they're not really what's needed. We're taking infrastructure updates and bringing them up to a regional lab, a district lab, where the laboratorians, the diagnosticians can operate safely and securely. This was an incinerator in one of our partner countries in Southeast Asia. As you might guess, it doesn't work so well. There was actually half of a carcass still in there. One of the issues that we run up against is not only does stuff not quite work, we have to do this sustainably. Can you figure out the supply chain? So we'll come up and build you a new incinerator. Have you been budgeting, lab director, for the fuel? Do your staff have the training to make it run? You know, how much can you load it? How often can you run it? For how long can you run it? And work them through that. How do you turn this into an operational system? Again, hoping to not provide an upgrade that will collect dust bunnies and not actually reduce any threats. Some of the updates that we provide are more high tech. On the biosecurity front, we do a lot of work in terms of access control. In some places, it's as simple as it would be good if there was a door on this laboratory. It would be even better if it locked. In some cases, we put in some biometric readers to allow access in. We've helped institutes develop access policies, provided them guidance and recommendations about when someone retires or leaves. How soon do you take them off the list so that they don't keep swiping themselves back in? Providing security cameras and the training and how to do that response as well have been very helpful. And then even more simply, this is a tire wash pit outside the front of the National Veterinary Lab in Entebbe, Uganda. They do a lot of foot and mouth disease surveillance. Their goal is to not help spread it around the country. And this is an easy way to help make sure that they aren't doing that. So not everything has to be high tech to get the job done. Mid-century modern aesthetics aren't really what you hope to see in a laboratory. So we have seen and removed equipment with manufactured dates in the 1940s. Some of them were still being, some of it was still being used. So it's always, again, how do you work with the system, work within the resources that they have to update and again, enable safe operations of the laboratory. I talked about training before. The training events that we offer cover the whole range of biosafety, biosecurity, biosurveillance. We have provided some clinical decision support training to help human and animal health clinicians understand how to go through a differential diagnosis, to try to get away from, you have a fever, you must have malaria, here's your antimalarials, have a nice day. And what else can you do, plus actual diagnostic testing, to help come up with a more definitive diagnosis. Laboratory biosafety and biosecurity training for the folks working in the lab, providing training to do serology and PCR. We have a tendency to not focus on classic microbiology as a diagnostic because of the potential for it to be used for nefarious purposes. Teaching somebody how to culture things for diagnostic purposes can also be diverted into less happy purposes. The other point is that the molecular diagnostics are often faster and more sensitive or more specific. We haven't had significant pushback from our partners in country on that approach. We do try to help them work through the supply chain restrictions and to help them plan their inventory. If you know it's going to take 3 months to get consumables back in supply in your national lab in your country, you know, how do you figure out how much I need to keep on hand for a given rate of testing, for an expected rate of testing? Our training is not just classroom or in the laboratory. We also drag people out into the field. The team in the upper left was a group being taught how to do safe sample collection and handling of bats in Eastern Africa. And so we also often have had some struggles with, particularly for sample collection, with PPE choices and utilization. There's a hesitancy to use a lot of their existing stores of personal protective equipment in training because they don't, it's a limited resource for them. Because we're able to come in and provide all of that material for the training and then help them source ongoing supplies of PPE, we're able to support ongoing safe sample collection. We provide the training for the packaging and shipment of specimens so that they actually show up intact at the laboratory and in a way that doesn't endanger whoever may be tasked with doing that transport job. And in some places, it's I put the cooler in the taxi, or I gave the cooler to the guy with the motorcycle who may or may not be a routine member of the laboratory system. The crew down in the bottom right is actually out doing tick collections for those folks who are vector people. We've also provided training in mosquito collection for both adults and larval specimens, and then followed it up with some training on the identification of the vectors that they collect. So the science program is the component of BTRP that I've worked with most closely. It really is a complementary effort to the training, the infrastructure development, in that it provides us, we are able to fund research projects, and that provides us with a nice opportunity to give an applied exercise for that training for the infrastructure development that we have funded. So we are often able to fund projects that will update and refresh the disease baselines for a country, that will help identify and characterize the strains of pathogens that are circulating in a country. Because we're focused on international capability development, the bulk of the work for our projects are done in country by our in-country partners. This is not a science research program where US researchers get to go to far off places and collect specimens, bring them back to the US or their home institution and do great and wonderful science with them. We want that capability to stay in country. And so what we really look for are researchers that are interested in doing that training and mentoring and development in country. So, like I said before, strengthening the durability of the capabilities that we have put into place. Because we have these ongoing 3 to 5 year projects, and sometimes many projects in a row in a partner institute, we get some transparency into the kind of work that they are doing, into the research that's going on in a particular country. We are also able to provide some research preparation training. It's hard enough when English is your first language and you kind of know what the bureaucratic language is to write a successful grant proposal to a US government agency. It's even harder when English is not your first language and you don't know what the heck the system is. So we have been able to provide grant writing training. We have been able to provide, at the other end, training on how to do technical writing, so for the production of manuscripts. These have been very successful. We had some researchers in Ethiopia who did not initially, their home institute did not initially think that they needed grant writing training. They thought they were doing okay with the skills that they had, but they were willing to send some of their junior staff to the training. And from what we can tell, those individuals took what they learned and shared it with everybody that stood still long enough. And over the next 12 to 18 months, the individuals from that institute drafted and submitted 24 proposals to organizations that weren't DTRA, and brought down over $1.5 million US in research funding. And suddenly they realized they could have a sustainable research program that institute had never considered was a possibility. And they are off like a house on fire, doing research with the likes of Oxford University, because it's a great big beautiful world, let's go. And so they're actively pursuing opportunities that they never thought were within their grasp. And then so at the end of the day, what we're looking to do is take these scientific engagements and translate them into those enduring outcomes and have that long-term impact. One of the ways that we can do that is by tailoring the partnerships that we have. And we've got some flexibility in how we're able to do this. Every country is a little bit different. They've all got different gaps. They've all got different bureaucratic structures. Sometimes there's a overarching Ministry of Agriculture. Sometimes agriculture and livestock and wildlife all come together. Sometimes they don't. Sometimes the animal and health organizations work well together. Sometimes they don't. Believe it or not, the national vet labs in some countries are better funded than the national public health laboratories. So we've been very fortunate in that we can tailor what we do to address the priorities and the gaps within each individual country. We can come in and provide that training to make sure that our partners are able to do the research that we need them to do and that they are interested in pursuing. And then through the development of networks of scientists, we're able, both within the country and with external partners, we can help build those enduring capabilities. So some of the projects that we've had underway in terms of research, the map, no, that's not going to animate, right? The map at the back is actually a risk map for melioidosis and the prediction of where it might be. So we know it's found in Southeast Asia. It's anticipated that if perhaps the surveillance was done, we might also find it throughout Africa. And there are some projects that are underway to do that. The map on top is looking at flyways for wild birds and how they might potentially be helping move influenza viruses around the world. And so we have been able to connect some researchers in the Caucasus across Georgia with some virologists in Uganda, trying to figure out where those viruses are there viruses in the wild birds being moved from East Africa up through the Caucasus and probably on further north. This gentleman is taking his chickens to market in Uganda. We had funded a pilot surveillance project to study avian influenza, provide some veterinary officers with the skills to do sample collection for domestic birds as well as wild birds. In January 2017, the Ministry of Agriculture was notified of a wild bird die-off near Lake Victoria and sent some of those team members out to do sample collection. They roped in the Uganda Wildlife Authority as well. Were able to collect specimens. They brought them back to their collaborators at the Uganda Virus Research Institute and were able to quickly characterize the virus and then communicated to Tanzania across the border on the other side of the lake, hey, this is what we found, heads up, it may be coming your way. And so very quickly, we're able to, within 3 months of when the pilot study had taken place, demonstrate their ability to recognize and react to a potential infectious disease event. The work that we're able to fund can help our partner countries understand what's circulating in their country. In Georgia, we were able to support work that identified new locations for tularemia that had not previously been studied, and so expanded the risk map, and thus, because of the connections back to from the project team back to the ministries, also helped inform some of the policy decisions and the communication out to the public. We've had some projects studying antibodies to especially dangerous pathogens in the wildlife population in South Asia. So identifying in bats and macaques some lovely viruses. And then in India, there is a particular area where there is a very large annual bat harvest. And the question that the researchers had was, what are the risks associated with that? Because the locals are not using PPE when they go into the cave. So what might be circulating? What should the public health side be looking for? So I've been at DITRA a little over 3.5 years now. I spent the first 3 years there working primarily on the Africa portfolio, and this is a project that is of I'm particularly fond of. They were seeking to identify what risks are there associated with bushmeat consumption. Technically, it is illegal to harvest bushmeat from protected areas in the country, but it's well known that it happens anyway. And Some of the diseases that kind of circulate around anyway include anthrax, whether you're eating bushmeat or not. Anthrax, Q fever, brucella were really the focus of the surveillance effort. This is a group of folks that are slaughtering an animal in a ditch. Our study areas focused around 2 national parks. The team involved members from the Tanzania Wildlife Authority, as well as the Veterinary Lab Agency, and had support from the Ministry of Health. The effort was actually based out of the Nelson Mandela Africa Institute for Science and Technology in Arusha. So all of the diagnostics were done there. The team worked very hard with the local communities to identify purveyors of bushmeat and to procure samples from them. So they were able to obtain both fresh and dried meat from purveyors of bushmeat. The first thing they did was to speciate the meat to make sure that when Bob, the seller, says it's zebra, that it really is. It wasn't always. Some things were more likely to be as labeled and others weren't. But then trying to associate which pathogens came from which spaces, which sites, in which seasons, and the correlation with dried versus fresh. During the course of the study, because they had a good relationship with the locals, the team gets a phone call and says, you know, there's a bunch of dead zebra. And so the team went out, helped the local wildlife officers do safe sample collection, provided them with PPE, brought the specimens back to the lab, did the diagnostic testing, and was able to establish that, yes, the cause of the die-off was in fact anthrax. But then they also noticed that it was apparent that some of the animals had been butchered. Hyena and other scavengers don't typically make straight line cuts when they remove chunks of meat. There was also evidence of hide removal. Hides make a great roof because they're waterproof. Tail switches are good for fly swatters. So the group sprang into action. This is what locally not using PPE and slaughtering a sheep which may or may not have already been ill looks like. They know that the consumption of sick and dying animals is potentially associated with anthrax. We see a lot of kids with cutaneous anthrax because they're the ones that will carry it, whatever's left over of the meat, to the next village to share. But with limited food supplies, limited protein sources, the animals get consumed. The team actually prepared, and I'll show it towards the end of, there it is, prepared materials in local Swahili dialects to explain the risks associated with the consumption of bushmeat and dead and dying animals that you didn't slaughter yourself. When we asked some of the kids with the scabs and the scars, you know, have you eaten an animal that's been recently sick? Yes. Do you know? Oh yeah. And we had one kid run into their house, collected the flyer, and says, yeah, I know all about it, and is explaining to us what the material said. So, but that was part of the community outreach that was supported through the project. The project team in the upper right and in the lower left has now established a laboratory at the Nelson Mandela African Institute for Science and Technology that is considered to be the reference lab for anthrax diagnostics in northern Tanzania. There is a clinical research institute nearby in Moshi that is using this facility as a surge diagnostic facility when they become overwhelmed with specimens. But the team as a group helped standardize in northern Tanzania the sample collection protocols and how the diagnostics were going to be done. So the final piece of the engagement from the science program standpoint, is the helping build networks outside of a given institution. We are huge proponents of our partners publishing the work they do and going to conferences and presenting whatever it is that they have found. We have the ability to provide travel support to our foreign partners to do that. So we send them places like ASM Biothreats, like the annual TROP Med meeting, the Conference for Research Workers on Animal Diseases in Chicago, which is always an exciting meeting for someone from a tropical country, since that's typically November or December of every year and often icy. We have, while we encourage them to actually come and present, we are willing to support them coming to a conference if they can justify to us what they would benefit from it. So I may not have a presentation at the TROP Med meeting, but I know that Dr. So-and-so is going to be there, and these are the questions I'm going to ask, and so we can facilitate that network development. They get out, become members of the greater scientific community. In many cases, these are early career scientists who would not otherwise have had the opportunity to make these connections. And so they're able to interact with the old gray folks that have been around for a while and can help them further develop their careers. And I gotta say, that's one of the most gratifying parts. We have the ability to help convene conferences as well, or to convene panels at conferences. This one's in Malaysia. And we're starting to develop what we call threat reduction networks. This is building off the NSF Research Coordination Network concept, where we bring together groups of scientists, either from within our various Rolodexes and contact lists, but also bringing in researchers from outside focused on specific subjects. We've got a melioidosis network going in South Asia. There's also a rickettsial disease group. Independently, each of the science managers in the BTRP were funding bat-related surveillance projects in various parts of the world. And we discovered this at a conference and said, wouldn't it be great if we got all of those bat people together? And on the fly, they came up with the idea of, we should totally have a bat disease network. We should share what we know. How do protocols in Asia differ from protocols in Africa? I've learned over the last 3 years that bats aren't all just little small flittery things that live in caves. There are some big things that are the size of seagulls that live in trees and have apparently no issue about flying around during the day. So as you might imagine, the collection of such critters varies greatly. It doesn't work to put the mist net up in front of the cave if that's not where they are. So bringing those individuals together spawned a number of research questions. We brought in some ecologists as well. So it's not just the bat pathogen research group, it's the Bat One Health research network. And they really are looking at what are the ecological factors associated with the bats that bring them in conjunction to the pathogens, and then the pathogens with the humans and the other animals, and going from there. So helping provide an opportunity for them to build a research strategy, and then bridging those various disciplines to help come up with some answers. This spider diagram was sort of, it all began with the yellow box in the middle. There was a bat surveillance workshop on how does one go about doing surveillance for pathogens in bats. And from that, all of these other activities and workshops and papers grew out of it. We now have the Western Asia Bat Network, WABNet, which is involving the Caucasus and Jordan in studying bats throughout that area and the pathogens they may be transmitting. Another example of this research coordination or threat reduction network is the Africa One Health Network. This was begun, again, by our collaborators. We sent a fairly large delegation to the One Health EcoHealth Congress in Melbourne, Australia in 2016. Had a social gathering so that folks could all meet each other, because there were probably 8 of us on the DITRA side and 30 some odd collaborators from around the world. The African contingent corners me and says, we need to do this Congress thing in Africa. We could totally do One Health. We already do One Health, and they started listing off the programs in their countries. So sat down, asked them to what would your objectives be? What would you want to get out of this? Identified a couple of folks to form the nexus of a steering committee. They generated goals and objectives. We provided some funding, and they had a Congress this last February, bringing together what they identified as the One Health stakeholders and champions from across the continent to try to unify the smaller regional One Health groups, and again, figure out where do we need to go next. They had the picture on the bottom is from a hackathon where in smaller groups, they sat and thought about what are the big lessons learned, what are the big priorities that we have in One Health, what are our gaps, and what do we need to fix it? And so they sat, and then each group had to present to the rest of the room, what do you think the malfunctions are, and how do you think they need to be? What do you need to fix this? And apparently that went over, was the best part of the conferences are great, but you can sit here and start chewing on some of the problems and share with everybody else how to try to tackle those. So that initial steering committee is now the core piece of the next group, and they are aiming at having another Africa One Health conference within the next couple of years. So we're looking forward to seeing how that continues to grow and develop. So that's a whirlwind of sort of what BTRP does in the One Health space. I'm happy to answer questions. My email is here if you do like I do and come up with questions after this event ends. Thank you for coming.
Thank you, Dr. Lancaster, for all that great information. As we do at the One Health Academy, it's our tradition to share with you a flag that's been flown over the Capitol. So thank you so much for your time and sharing all of your experiences and information with us. We really appreciate it. And yeah, I will just ask if you don't mind repeating for the webinar folks the questions that get asked in the room. We've got about 5 minutes, so any questions? I'll just go start.
I'm just wondering what says the Global Health Security Initiative is and how it's connected. I'm wondering if there was an event where, for example, in the last week, we've gotten a report that a lot of tribal people are dying in the eastern part, and the western part of Brazil in the Amazon. What do you do about that? Where does if it came to your attention, what
right?
Does it go?
Yeah. So I'll answer the question that was asked was, how does GHSA intersect with our program? the second question was, in the event of an unusual event, such as a mortality event, and the example given was Brazil, what would our program do? The second question is the easy one. Because we don't do response, and we're limited in the number of countries that we're involved in, so our program is not does not have any engagements in South America or Central America at all. So in that particular example, we wouldn't be involved. If this was something that was occurring, say, in Uganda, there's certainly concern right now that the ongoing Ebola outbreak may spill over the border. Again, we're not in the response business, but we can help support efforts for preparedness and for diagnostics and for sample transport. So making sure that our partners in our countries have the ability to launch an appropriate response, that they have the training, that the laboratories are adequately equipped, that they have the technical support that they need, is where we would work. And for other asks, we would then try to partner with other either U.S. government agencies or other international partners to try to get those other gaps filled. For GHSA, our programs are complementary. We don't get GHSA funding, but the work that we do aligns with one or more of the action packages within GHSA. We do strongly urge our partner countries to be involved in JEEs and to help develop their action plans following the evaluation. But we can also, our efforts, we make sure that when GHSA activities are being captured for reporting purposes, that the countries are taking credit for the work that they are doing with our program. So we often have coordination calls with the in-country GHSA coordinators to make sure that they've got the information about what we're doing.
Very much enjoyed your overview. DITRA, I presume, has a global area of responsibility. When we were working in West Africa, Ebola, with Africa COM funding, we had developed a set of lessons learned. You know, the British Army no longer uses the term lessons learned. They use lessons identified because we don't seem to learn. We had set up a presentation, in fact, an entire workshop that we had negotiated with PACOM, now Indo-PACOM folks, to basically, they were interested in learning all the lessons they could from West Africa. So if anything similarly happens among their countries in the Asia Pacific region, they are a step ahead. Ultimately, the PACOM leadership said, no, that was Africa. Would it have been appropriate for us to come to DITRA to become the broker, the global broker for something like that, that transcends to the geographic combatant commands? Now, I'm talking a lot of Army-E's, I appreciate military-E's, but regions, inter-regional workshops, regional.
Yes, I would say yes. So one of the things that our program tries to do is to identify those commonalities, and to think certainly regionally, if not between regions. Again, there's a lot of young folks in our program, so it hasn't occurred to them that they shouldn't learn from the old history where we haven't always followed through. As you pointed out, the lessons learned versus the lessons identified. We're always trying to think creatively about how do we get all of the knowledge everywhere it needs to be. So I think in a situation like you described and trying to get the lessons from one continent to another, that we could help facilitate that. We certainly have good connections within the combatant commands, specifically within the surgeons' offices, to help push information out that way, as well as more directly through our in-country collaborators at the various ministries, and in some cases the ministries of defense. Yeah.
Yeah, the surgeon's offices were all on board.
Right.
But when it went up to leadership, they said, wait a minute, why do we in Asia need to learn about Africa?
Right.
And that was not.
And now that there's Ebola virus antibodies identified in Asia, folks are maybe rethinking.
Thank you.
So where do you find that your areas of most success are? Would you tie that to, say, geographic areas or more programs that are stood up? What are the metrics that you would use to, say, assess what your highest return on investment is?
Right, that's a good question. We have struggled with metrics and evaluating what success means. All of our countries now have a set of baseline metrics, so we've sort of figured out where everyone's starting at, and certainly countries like South Africa or Thailand started at a different level than Liberia. For each of the lines of effort that our program has, the country managers have established goals and end states that they're trying to achieve, and then develop their project plans around those goals, and tailor them that way. There is an annual review of how much did you accomplish. This is certainly, we take into account the political environment. Occasionally there's an election and the folks that we were working with aren't there anymore. The new administration may or may not be as willing to help. So we can have some hiccups in our progress, but we have established a metrics system to sort of track where we go. We have not brought it down to the level of, how much improvement in diagnostic testing per X dollars spent, but we are getting past the how many people did you train in whatever subject this year.
Thank you for the talk. I was wondering if you could talk further about how you decide what countries to work with, specifically why not Central and South America?
Yeah, and this was, so I'm from the Department of Energy, and before that, public health, so I had no experience with how does the Defense Department decide what it does. And I've discovered that there's this place called the Office of the Secretary of Defense for Policy that comes up with, there is a prioritization of countries, and so we get a list of priority countries. There is also a thing from the Pentagon called determination, and it's essentially the permission and authorization to go and do work in that country or in that region. So in Southeast Asia, in the former Soviet Union, and in the Middle East, we have country by country determination where we can go, where we have permission to go and engage. The continent of Africa is a little different in that we have blanket determination, but our policy shop has prioritized the 10 countries that we are currently engaged in as being the highest priority. And there's some tiering within that list of countries as well. And some of that is based on the agreements between our countries and what each country is willing to have us do. And some of it is based on a risk assessment.
All right, we're close on time, you guys. So Dr. Lancaster has graciously agreed to speak with anyone after the talk. If you might want to have it in or any of the local bars, we have a short time here at ASM. So thank you so much all for coming, and thank you again, Dr. Lancaster, for your presentation. All right, the only thing I will add, yes, thank you, Tanya. If you have not signed in, please sign in the back, because at the back allows me to connect you with the speaker and with everyone here. And then please pay Tanya right here in the blue to keep us moving and forward and keep you guys fed. So thanks so much. Please grab my name or include that. And we have one more session before we take our summer break. So next June, next month in June.
Have you ever worked with a fellow by the name of George Anderson?
And that's second Wednesday.
George is a PhD, medical service
Thank you
corps
guys so much for coming tonight.
immunologist.
Yeah, have a great
Retired
evening.
from the Army and went to work
It's not
in
raining.
Georgia. And he helped build that BSL Ford lab. And now he's at Lawrence Livermore.
Oh, okay.
So I thought all of you national lab folks have a secret handshake.
Yeah, right, exactly.
Everybody
Yeah.
seems to